allora proviamo. Well, I'm just trying to get in from my phone because Katia is telling me that she can't see me. Katia, mi vedi adesso? No. È perché c'ho tutto disabilitato, non posso abilitare nulla. Serena, perdonami, tu mi vedi?
No, assolutamente. No, Rosanna.
Allora provo a uscire e rientrare perché veramente non so cosa fare. Non ho altre opzioni. Ieri funzionava tutto bene. Provo un attimo a uscire e rientrare. Come devo... Ok. Okay, good afternoon, everybody. And can you hear me? Okay, so welcome to this webinar today. This is the first webinar of a series of webinars focused on how to recognize and manage emergency and urgent situation in Sanfilippo syndrome and related diseases. I am Rosanna Yellow, Scientific Office Manager of the Patients Association Sanfilippo Fighters, based in Italy, and I will be the moderator of this webinar. First of all, I would like to thank MetabERN and the MetabERN educational program headed by Professor Eskin for their wonderful help and support in designing these webinars. And I must say that probably if it wasn't for them, we wouldn't be here today holding this webinar. And then I would like to thank our speakers for today, Serena Gasperini from the Hospital San Gerardo dei Tintori in Monza, and Lucia De Zen from the Children's Hospital Burlo Garofalo in Trieste. They are amazing professionals and collaborators of Sanfilippo Fighters. Just a few quick information before we start. As you can see from the slide, this webinar is going to be recorded for educational purposes, and it will be shared on MetabERN channels and Sanfilippo Fighters channels. If you have any questions, you just need to write them in the chat, and I will read the question at the end of each talk. There will be a Q&A session, and I will read the question to the speakers. If a question does not come to your mind today, you can send us an email at the email address science@sanfilippofighters.org, and we'll do our best to give you an answer. Last but not least, this is an accredited webinar, like will be the other webinars following. So it's accredited for physicians, so physicians that registered for the webinar and are going to attend the webinar will receive an email at the end of the webinar with their attest. I think we can start, and I can leave the stage to Serena Gasperini. Serena, when you're ready.
Thank you, Rosanna. And I try to do my presentation, and thank you to MetabERN and to Sanfilippo Fighters to invite me and for this great opportunity. And thanks to the auditors to be here in this day of San Valentin. In my speaking, I touch some points when there is an urgency or emergency treatment for a patient with Sanfilippo syndrome. And you know that MPS 3 or Sanfilippo syndrome firstly was described in 1963, but some symptoms of this disorder are specific and peculiar, but many of them are common to other lysosomal storage disorders and other neurodegenerative disorders like progressive mental delay or epilepsy or sleep and behavioral disturbance. And there is a wide spectrum of disease, you know, between different forms A, B, C, D, and there is also a phenotypic continuum from severe form to attenuated form with only mild mental retardation, and epigenetic factors are involved other than genotype. And every patient is quite different from another, also in the same family. This is a peculiarity of this kind of disorders. So we can expect many symptoms that are common also to other MPS syndrome, like valvulopathy with need of prophylaxis for endocarditis, or tracheal and upper airway stenosis, pain at teeth and with the tooth, and obstructive sleep apnea syndrome that can have a great impact in the sleep and during the day, in the activity during the day. Dysphagia is another great problem for these children, and nutritional disorder with sarcopenia, loss of weight, and also sometimes dehydration can lead the patient to the emergency room, and sometimes they need gastroscopy for nutrition. Epilepsy is another problem, and behavior disorders with hyperactivity, sleep disturbance, and sleepiness and aggressiveness. And also we'll see together with Dr. De Zen, the pain is a great problem in this case for this disorder. But we can see here the difference in this very important paper that analyzed the biomarkers for predicting disease course in Sanfilippo syndrome is very different, the healthy brain to the Sanfilippo brain. For some reason, the storage of heparan sulfate can create the trigger factor to do a neurodegeneration, but there are other factors involved in this process, like an alteration of neuroaxonal trafficking, of autophagy, and of diffusion of autophagal lysosome, with alteration of the neurotransmitters that is typical of Sanfilippo syndrome and different from the other mucopolysaccharidosis, and also a damage in mitochondria. So there is a polyfactory, and the neurophysiology is very peculiar in these disorders, and the pathways involved are many pathways are different. The storage is a storage of heparan sulfate, as I said. There's increase in plasma, urine, and also in the liquor in CSF. But there is a great role of neuroinflammation and of the neuroaxonal degeneration with alteration, as I said, of autophagic pathways. So we have a polymorphic role of many factors in this case, in this disorder. This is very peculiar to lead also a synaptic function alteration that is typical of the to cause the fluctuating symptoms, the on-off symptoms that is peculiar of this disorder. And we have, many biomarkers for to search for neurodegeneration. We are searching for the specific biomarker, because the biomarker you can see on the right, tau protein, neurofilament, alpha-synuclein, are not specific, but are in common with all the other neurodegenerative disorders. So we can expect in our children the comorbidities, disease-related or not disease-related, that can cause many symptoms and lead them to emergency room, for instance. Epilepsy is more specific. Also, the headache or the behavior disorders, increase of intracranial pressure or respiratory obstruction, abingestis pneumonia, and dysphagia are peculiar of this syndrome. Other comorbidities are common with other chronic disorders, with diarrhea, vomiting, otitis, stipsis, cystitis, abdominal pain, gastroesophageal reflux, or bone fracture, dental pain. And caring complexity is a very complex and many chronic disorders led to this disability and to this fragility. And we need a patient care model to have a general vision of our children with a multidimensional and multisystemic approach to have and to reach a supportive therapy and also a symptomatic therapy. These things depends also on disease progression, on type, on form, and on form of disorders, and on children peculiarity, obviously. Sometimes and often, unfortunately, the diagnosis of Sanfilippo syndrome is late. An early diagnosis is expected, and we hope in the future for the help of newborn screening to identify this disorder and to identify early the complication and to can treat with new therapies, a new therapeutic approach to this disorder. We have to refine a new role sometimes and during the life day and the daily life, the role of the family doctor, and we should ask for his or her help, because the family doctor is not an expert of this disorder, but is involved in the chronic disorder at home, and we need him or her to face the fragility that are crossed between many chronic disorders and can alleviate the heavy daily life of the family to improve quality of life, especially with infection or with some problems with the home resources or the device. And the family doctor should be not a ghost, but a great resource, we hope, to involve and play a great role in this case. He has a great role also in the rehabilitation, in device or aids, and also in comorbidity, infection comorbidity, in pain, and also in the palliative care in the terminal phase of the disorders. But we need to involve him or her in all the passages, in all the network care. The attention we have to put in our children is in the symptoms and in the clinical signs. Sometimes the changes in the ordinary behavior or in ordinary everyday life can be an alert for us in our children, for our children. The difficulty is to not excite symptoms, but not underestimate symptoms. It's very difficult, and it is a challenge we need to do together with the family, because sometimes our children had, as I said before, an on-off effect with a physiological fluctuation, not only during the day, but also during the week, on the month. Sometimes they have a long period with different behavior, and we don't explain it, but we have to searching for cause of other, to search for and to solve them. But we have to keep in mind that the peculiarity of this disorder is typical of and justified itself a fluctuation, because neurotransmitters and also synaptic alterated pathway can justify this. So when you must call a doctor and you must send the children in ambulatory of the medical doctor or the family doctor or the specialist for ambulatory management, You can phone a doctor when you have many symptoms like gastrointestinal symptoms, and if you occur a dysphagia and an early dysphagia, if the meal takes a lot of time, or there is cough during meal. If you have some symptoms like infection, cystitis, that is a great problem for these children sometimes, but also diarrhea, stipsis, abdominal pain that are very frequent in our children, and also gastroesophageal reflux. Other problems that are current cause of a call of a doctor are respiratory problems, respiratory symptoms like cough, fever, otitis, or excessive oral secretion. And another great group of symptoms that require a call to a doctor are the neurological symptoms, like pain, hypotonia, aggressiveness, of sleep disturbance. These are this symptom can be faced with not emergency, but if they come severe, they need an emergency approach. And when you must go to emergency department, according also to the literature, for this kind of children, the major reason to go to emergency department and to call an ambulance are the acute respiratory ENT related complication, like persistent cough with cyanosis or apnea, or severe dyspnea. And we can have it with fever and with an acute obstruction of the airways, upper or lower airways, or we can have also a progressive symptoms acutized during an infection. Other symptoms are neurological symptoms with prolonged and complex seizure, with the severe symptoms, and with an acute also hyperactivity, with the change of acute and severe behavior disturbance, and also hyperkinetic crisis. Other symptoms that led our children to emergency department are lethargy or coma. Another great chapter is the gastrointestinal problems, like persistent vomiting, loss of nutrition or dehydration due to infection or due to loss of nutrition, and dislocation of device like gastrostomy is an acute problem to solve. Other problems are the severe infection like Emergenze pneumonia, or like sepsis, if the fever is very high and don't decrease with common paracetamol or other drug. Other problems are also the pain, and Lucia De Zen in the follow lecture can explain better what we mean. The pain is a great problem, as I said, in these children, in our children. So sometimes we need what we call emergency letter, that in some cases is very important to face the problem, especially in emergency, during when we have no time to study or to understand better what is the natural history, what are the main complications of this disorder. So the emergency letter generally is tailor-made with a clinical condition and the state of disease progression of the patient, the type of disorder, the form of type of Sanfilippo syndrome, the risk and complication are peculiar of the disorder, and also if needs palliative care, is the patient is on palliative care. These are great, this information have a great importance for the doctor who received the patient in emergency room, because there is no time often to study, as I said, and many complications are disease related. So it's very important to have many information in a short time. In Italy, we have this book wrote many years ago and updated recently from the genetic and metabolic team that in Italy wrote this informative and this suggestion for every main disorder like MPS 3. And so the emergency doctor can read in a short time many information, precious information to face the problems of the child or of the patient. There is also an app that is available on the phone device that can help us. And also the guideline have a great importance. This is the recent guideline that in 2022 was written to decrease the diagnostic delay, but also to give indication also to the expert doctors for the natural history of the disorders, and also for the critical area of evaluation and follow-up, and also the timeline of follow-up that is very important to follow in our patients. And these information are very important, not only for the expert, but also for the family doctor and also for the emergency doctor. And another great problem, as I said, was the seizures management, especially during the emergency, in the emergency room. And many of our children, about an half, develop seizures at different age. It depends also by the form of disorders. And they have both non-convulsive and also convulsive epileptic status with continuous, they can have continuous seizures, generalized tonic-clonic seizure that can condition the breath and can condition the healthy of our children and the need an emergency treatment. But both convulsive and not convulsive epilepsy should adequately treated, but sometimes they are difficult to detect and discriminate and need a correct diagnosis. So if the behavior of the symptoms of the child persist and are continuous, they have to go to the emergency room to do an urgent and EEG monitoring of the brain waves. And another point to discuss with you and with the specialist is the peculiar anesthesiological risk of these children. Especially the main characteristic of the stenosis and upper ways airways obstruction, and also the risk in intubation and also extubation of these children are very important to calculate, and also the cardiomyopathy and valvulopathy. And another risk, the risk of myelopathy, with the mobilization of the neck and of the head during anesthesia for odontoid hypoplasia. So these information are very important to manage these children and our patient in emergency room, also for surgery and also for sedation for procedures. And it's very important because anesthesiology often is difficult and sometimes is impossible in our children. So we have to put in the emergency letter this information. It's very precious for the anesthetist. And this is the main problems I said before, but preventive evaluation and the personal emergency anesthesiologic card is very important for us. We have in our hospital, who follow the patient, but not in every hospital you can go and the children can go. So it's very important to think about an emergency card as we do for other disorders, for like beta oxidation, because we can think it with MetabERN and with the help of the association. I think it could be a very important thing to do. And in our hospital, we manage the complexity of this disorder with the help of a multidisciplinary team, because without it's impossible to manage this very complex patient with an anesthetist dedicated to this child, with a dysphagia team, with a pain management, a palliative care. And we have all for one monthly meeting to share guidelines, to share and individualize the treatment of every patient. This is very important, and only together, if we work together as a team, we can realize all our dreams. The dreams we share with the families, with the association, with our children, at which we promise new opportunities, new hopes, and new treatments. So all together we can do more and more things, and we can give hope to everybody. I thanks everybody that cooperate with me and help me every day with all the multidisciplinary team in Monza, and thanks you again for your attention.
Thank you, Serena, for your wonderful talk. I'll give a few minutes to our listener if they want to write a question. And in the meantime, I have a question for you. You talk about the emergency letter. So my question is, a family who wants to write an emergency letter, to have an emergency letter with them, how should move? To who should ask to have the emergency letter for his child, for a child?
With MetabERN, in other cases, for other disorders, we wrote a general emergency letter that we can personalize. I imagine it can be possible to do also for Sanfilippo, because there are many problems, many complications that we share with all patients, and then we can individualize with the anesthesiological risks. In my mind, I think so. It could be possible, because there are some indication to avoid some drugs, to avoid some procedures like extension of the neck that can be shared for everybody. And we can think with you and with MetabERN and with all the experts to do this.
Okay, so it's not something that could start from the family doctor in any case?
No, I think not, because as I said, all these points are made by experts. As I said, the app or the book are made by experts in genetics and metabolism, but we can share it with the emergency room, with the medical doctor, the family doctor. It's very important to share with them and to play in network.
Okay, thank you very much. And if there are no questions, I think we can go on with Dr. De Zen, if you're ready.
Yeah, I'm ready.
Okay, stage is yours.
So, yeah, so I share my device, and first of all, I would like to thank the organization for inviting me. It's a great pleasure to be here with you tonight and to discuss with you about a theme that I feel it's really important. I'm not a specialist for Sanfilippo syndrome. I'm a pediatric palliative care and a pediatric pain therapy specialist. And my aims for these next minutes is to underline the importance of pain management in Sanfilippo syndrome, and this is for me an aim that I feel very, very important. And so I sorry, okay. Sorry. First of all, my lesson is constituted by 5 points. First of all, the definition of pain, then a focus of pain in Sanfilippo syndrome, some critical issues, what we can do, and conclusions. My lesson is not really a lesson on pain treatment because it's really too long and it's too complicated, but I would like to underline some important message. First of all, definition of pain. Pain, according to International Association for the Study of Pain, is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Most important thing to remember is that pain is always a personal experience, influenced surely by biological, psychological, and social factors. Through our life experience, each individual learns the concept of pain, and it's important to underline that a person's report of an experience as pain should be respected. And pain is always considered as having an adaptive role, but it may have adverse effect on function and social and psychological well-being. And I think that it's really important to remember that verbal description is only one of several behaviors to express pain, and that inability to communicate does not negate the possibility that a human can experience pain. Okay, I like to discuss about the significance of total pain, because usually we consider pain as a physical pain, nociceptive, like somatic or visceral pain, neuropathic pain, or mixed pain. But it's important to underline that the pain is a total pain with emotional, social, spiritual elements that really impact on child and family experience. Pain in Sanfilippo syndrome is a common symptom in mucopolysaccharidosis patients due to the storage of glucosaminoglican and inflammatory state. And so we can consider that it is a chronic pain surely for disease, but also for intercurrent acute episodes. We can remember that they are children, and like every children, they can have something different from the Sanfilippo disease. And also for medical procedures, going to hospital, we needed to do many procedures, and each procedure needed to be well treated according to pain that can accompany the procedure itself. And it's important to underline that I found this study from about 10 years ago, where the authors reported in mucopolysaccharidosis that the highest frequency of pain is observed in MPS 3 group, more than 50%, followed by the other mucopolysaccharidosis disease. And patients with cognitive impairment have higher frequency of pain than the other patients, and a few patients use pain medication. And I think that it is a really important work, this really important paper, because it underlines the importance to consider pain in all our patients. This is a really recent paper published some months ago, where the author considered the humanistic burden of mucopolysaccharidosis, and they report that the quality of life of mucopolysaccharidosis patients that are not really focused only on Sanfilippo syndrome, but only to mucopolysaccharidosis patients, but their quality of life is influenced primarily by severity of the disease, and then by time of diagnosis, pain, cognitive involvement, mobility dependence, and time of treatment initiation. It's important to underline that pain is one of the first elements that impact on quality of life. That is a frequent symptom, and really it's capable to significant impact on quality of life, not only of patients, but also of caregivers. And this is a paper where they consider only mucopolysaccharidosis type 3. I underline that it's quite rare to find papers and publish on pain in mucopolysaccharidosis, dedicated to pain. And this could be a consideration that we can share during the discussion, because it was quite surprising for me not to find a lot of papers, a lot of work dedicated to pain. And so, but we can discuss about. And this paper underlined that what they do. They assess pain scores by a quality of life questionnaire and a semi-structured interview of parents and caregivers. They consider 12 domains, in particular with 2 questions addressed to pain. And the scores range from 0, the worst health level possible, to 100, the best possible health level. I reported the 2 questions, and the result underlined that patients with the development quotient higher than 50 had similar mean of quality level score to general population, 28. But patients with a baseline cognitive lower than 50 had a lower mean quality of life score of reported 74. And pain appeared to worsen over time and in older population of more impaired patients. And the Porter group published 2 works dedicated to Sanfilippo syndrome. The first one, they consider that even pain is reported as one of the most important symptoms capable to significantly impact on the quality of life. According to this study, pain is the first physical symptom that doesn't find a good treatment, the right treatment. So pain are reported by parents and caregivers as one of the first unmet treatment needs, not only for the child, but also for the family together. And so, which are these critical issues? If we consider that pain is a common symptom in Sanfilippo patients, we have few data available on its real frequency, probably because it's poorly assessed. The underestimation of pain in this population can be explained, according to me, by two elements. We have a difficult clinical evaluation due to the complexity of the disease, and unfortunately, we find the presence of cognitive impairment, and this could be an element that limit the evaluation of the pain. And in this work, parents worry about their and healthcare providers' inability to correctly identify and manage pain. And this is a reporting expression of a mother. And she that is quite significant for me, because this mother reported that, according to their child, even when she was younger, she would express pain, but you didn't know where the pain was coming from. It was hard for her to locate where the pain might have been, even though she had a really high pain tolerance. And it was, as I dedicated to pain and palliative care, it's really important for me to underline that a parent reported that the child has a really high pain tolerance, because I think that the level of tolerance probably could be considered high, as we are not able to really identify and evaluate the pain. But it is a comment that we will consider in the next slides. And this other work confirm what I'm explaining to you, and that parents report that their child have a high pain tolerance, then that frequently are not sure if the child is experiencing pain, and they are not always capable to know if the child is in pain versus some other causes of distress. And also, this is really important, that the facial expression or sounds expressed by the child as primary symptom expression of pain are not really so easy to understand. And so, what we can do? First of all, we can assess the pain. We find pain if we look for pain and we measure. And for pain, we can use different scales according to the age and cognitive situation. This is really like a presentation to explain to you that we have different tools. And these tools is dedicated to children lower than 3 years old. The name is a flux scale. And this scale consider 5 domain: face, legs, activity, cry, and consolability. And the pain range from 0 to 10. Sorry, 10 is a severe pain. Then, with the increasing age, we can consider Wong-Becker scale for children higher than 3 years old. And for children higher than 8 years old, we have the numeric rating scale. But we must consider that, unfortunately, children affected by Sanfilippo syndrome or other mucopolysaccharidosis syndrome can present a cognitive impairment. And this is some comments dedicated for all children with cognitive impairment, not for mucopolysaccharidosis children. But it's important to underline that children with a cognitive impairment present more severe pain than others, more than 10 hours a week. severe pain, not pain in general, but severe pain, more than 10 hours a week. And that 90% of children with cognitive impairment have chronic pain for a global time longer than 1 year during childhood. And that's also important that these children have different ways to manifest pain, from freezing, that is, they are completely blocked with no expression. And sometimes we consider no expression as no pain. Or these children can smile, and we consider that smiling is no pain. But really, for them, these expressions are equal to pain. And this is some other behaviors we can find in children with cognitive impairment. And this is a list, but is also an example to explain you that these children express pain different from the others. And so pain is difficult to understand, and parents and caregivers have a central role. Because we needed to measure pain. And how can we measure pain in children with cognitive impairment? The previous tools I explained you are not useful because they are not adapted for children with cognitive impairment, because we need different specific tools for these children. And we can consider two main tools: non-communicating children's pain checklists post-operative. And this tool is constituted by 27-item pain assessment, and the moderate to severe pain is determined by a cutoff of higher than 11 out of 81. The other tools is the revised non-communicating children's pain checklist. It's composed by 30-item pain assessment tools designed for, again, non-verbal children aged from 3 to 18 with severe cognitive impairment. The moderate to severe pain is determined by a cutoff higher than 7 out of 90. But I think that's important to underline, and here I have an example. This is the non-communicating children pain checklist revised. I think that really this is a very useful tool, but as I discussed with many parents, it's not so easy to complete, and because this tool consider many items, and if we need to measure pain, we need a very easy tool capable to quickly underline if a child is in pain. And my suggestion, my proposal is to use the revised FLAC. Revised FLAC is the FLAC I presented to you before, considering the 5 items. And the FLAC Rev include pain behavior specific for children with cognitive impairment. The score ranging from 0 to 10, like the FLAC I presented you before. The most important thing, according to me, is not only the simply compilation, the simply schedule, but also because this tool allows parents to individualize by adding behaviors specific for their child. So this tool has a free area where the parents can include the typical behaviors that, according to them, the child presents when he has pain. It's sort of identity card, and I suggest to my parents to bring this FLAC Rev always with them, because it's really useful to correctly manage, evaluate the pain of the child, mainly at the emergency room, where the doctor, they found, probably doesn't know the child, and it's not easy for the doctor to assess, to evaluate the pain if the doctor has not the correct tool. And this is the FLAC Rev. This is to report that with the general description of face, legs, activity, cry, consolability. The parents might add with the doctor together, because it's a sort of shared work. They can report the individualized behavior described by the family, by the parents, for the face, for the child, for the legs, for their child, for the activity, for their child, and so on. And it's a really personalized tool. And so another thing we can do is the treatment. This is a picture that summarizes all we can do for pain management, and it's really a lot of things to do. We call pediatric multimodal analgesia. You can consider that we can treat pain with a basic analgesic, with adjuvants, but also with psychology, integrative therapies, regional anesthesia, opioids, rehabilitation, and so on. And so we have a lot of work to do together for pain. And this is only some consideration regarding the pharmacological therapy. It's fundamental to correctly use the analgesic for treat pain. And this is 3 important rules. We consider the treatment by the clock. This means at regular intervals, avoiding if we need, if it's need, but give regular intervals. So avoiding that the pain is increasing a lot and we must run to the pain. And the second rule is by the mouth. We must choose the appropriate route of administration, and then I have some comments. And the third rule is by individual. We need to adapt the treatment to that child, because every pain is different for every child. And non-pharmacological therapy, yes, we have a lot of, like I explained you before, a lot of work to do for total pain, considering emotional, social, and spiritual pain. We have psychological interventions. We can do acupuncture, transcutaneous electron nerve stimulation, and physical therapy like massage, hot and cold, physiotherapy, and so on. And another element I think we can do, or probably we must do, is research. Research in which terms? In terms of write together guidelines for assessment and treatment of pain. We need wider studies, including also evaluation of treatment used by patients and their results. We need to consider the problem that many drugs useful for pain are used off-label. This means that are not licensed. For instance, gabapentin is not licensed for neuropathic pain, and this is a work that with my team we try to every day to consider, because we think that the children need to have the correct drugs, and so we needed to study very well the drugs we use for them. And also another important element is the use of compounded drugs, for instance, gabapentin syrup. Which is the comments I can do on this element. The comment is that most, or I think all caregivers often manipulate drugs before administration. For instance, grinding the capsules or melting the powder, because they needed to make them suitable for the child or for the feeding device. And with this operation, with this action, caregivers need a lot of time every day, and this leads to a high risk of high errors, in mistakes in the dose or in timing of the administration, or in the compliance and treatment adherence. And so also here with my teams, we try to find the correct formulation for the child, according to the capability of the child to assume the medicine, or according to the feeding device, for instance, nasogastric tube or gastrostomy. And so in conclusion, what can we say? We can discuss about the fact that Sanfilippo patients, like other mucopolysaccharidosis patients, probably more than other patients, often experience chronic pain, and the pain is poorly assessed and undertreated. I did in the last days to prepare myself for this presentation, a review of published work in scientific literature. And I underlined that I really find very few work reporting pain evaluation and treatment in mucopolysaccharidosis. And we are sure that, according to the paper I presented you before, that pain has a negative impact on quality of life. We need more studies to better understand the physiopathology of pain, its assessment and treatment. And this is a phrase that, a words that I found in one of the paper I read for this presentation. This is a mother, and mother explained that our expectation, are their words, our expectation in what we would like to get from treatment for Sanfilippo syndrome is relatively small, because some of those small things have a big impact on our quality of life. And with the read I had in the past days, I can say that a small things is to together evaluate pain and together treat pain. And this is a picture from Trieste, and also my city. And also I thanks organization and thanks all of you to be here together to discuss about pain. Thank you very much.
Thank you very much, Dr. De Zen. Wonderful talk. It's really it's really hard to manage pain, and we have a few questions. I'll read it for you. Okay, first question: the tools mentioned for pain evaluation, like the FLAA, for example, do they need to be officially translated for a clinician to use it, or are they translated in several languages already?
There are several languages available for FLAC, also for Italian version, and we currently insert FLAC revised scale in the clinical documents of our patient, and we prepare the scale for each child together with the parents, usually the mother.
Okay, who does translate it? Is there an organization or a...
But the Italian version was published some years ago. I remember, I think about 10 years ago. And I don't know if, but I'm quite sure there are other languages, for instance, Deutsch language, probably the group of Berlin from Zernikoff, they translated. And so, but if you want, I can check other language. I know English and Italian, sorry.
Okay, no, this question comes from our friend from Sanfilippo, Portugal, Raquel.
Mm-hmm.
And I think this comes from the fact that we translated the guidelines for Sanfilippo syndrome clinical management. Mm-hmm. We translated it in Italian, and she translated it, her organization translated it in Portuguese. And maybe, for example, if Portuguese is missing in the translation, do you think she can work on it to translate it in Portuguese?
Yeah, I think yes. I think it's a really good idea, because the scale is really easy to translate, and we needed to have a cultural adaptation in the local setting, but it's really a very easy action, very easy work. Okay,
and there's another question. What you know, does a doctor normally use them? I mean, are they known from doctors? Do they often use the scale? Or it's something that sometimes got, forgotten?
Okay. This is my work. I always remember also to my colleagues to use pain tools, evaluation tools. And I think that this is a joint action we must do, because for me, as I'm a pain and palliative care specialist, pain is really every day the first thing I think about my patients. So when I discuss with the colleagues, the first thing I ask to them is, have you evaluated the pain? Have you the correct tools for evaluate pain? So I think that's really a culture, a knowledge and the skills that doctor need to have. But I'm not really sure that every doctor uses every day these tools, but I think that if we continue to talk about pain and evaluation tools, I think that we can improve it. Also because, for instance, in Italy, we have a law, and according to that law, pain need to be evaluated and treated. And so it's a duty for us.
Okay, so maybe HAS as patient organization can help sharing this work, I mean, raising awareness on the use of this scale.
Yeah, I strongly believe in it, and also because it's important. When I prepare the scale with the mothers, I always tell to mothers, bring the scale always with you, because you need to present in every, also with the general pediatrician, for instance. And I discussed with the general pediatrician, what do you think about the scale? Do you think we have correctly completed the scale? And really, it's the scale need to be always with the child, because it's the verbal expression of the pain of the child. If we don't use the scale, we are not able to understand the pain of the child.
Okay, thank you very much.
You're welcome.
And if there are no more questions, I think we are done for today. Perfectly on time, I think. 5 minutes. It's perfectly fine. And so thank you again to our speakers. And you are amazing. And thank you for your work with children, with organization. We really believe in cooperation between you and us. And thank you for always being willing to help us. Thank you very much. And I take this opportunity to remind you all that there will be another webinar on the 7th of March. And that webinar will be specifically focused on neuronal, emergency, and anesthesia. So I invite you to join us for the next webinar, and I leave you with a good evening and a happy Valentine's Day. Thank you very much for being with us.
Thank you.
Bye. Thank you. Bye.
Bye. Bye.
Bye.
Bye.
Ciao, everybody.
Thank you. Bye. Bye. Bye.